I'm Rob Danzman, and this is The Better Semester, where I provide insight and actionable advice to parents of college students. I'm a nationally certified counselor and licensed clinical mental health counselor. All right, welcome back, everyone. Today we have Dr. Jessi Gold, psychiatrist and chief wellness officer at the University of Tennessee. Jessi, thanks so much for being here today.
Thank you for having me.
Absolutely. All right. So to get started, I'd love for you to share a little bit about kind of your origin story. How did you get started? Where did you go to school? Degrees, all that good stuff, just so that we can set a little bit of context, and then we'll build from there.
Sure. Hero or villain origin story.
Well, that sounds like a projective test.
I don't know. Just figured I'd ask that.
I think we're all on the hero's journey. So let's go with the hero's version.
That's fair. Starting how far back? Just keep going.
Oh, actually, so where did you grow up? Why don't we just
that's
kinda,
a good, yeah.
yeah.
I grew up in Florida. I was born in New Jersey, but we moved when I was I started really first grade on, I guess, in Florida, and we lived in a couple cities in Florida, but mostly North Florida for me, like Jacksonville and Gainesville.
Gotcha. And so did you stay in the Southeast, or did you go to school somewhere else?
These are good questions. I moved for every time I could move. I was convinced that if I had select periods of time, it'd be a cool time to move and see new things and learn new things about a place. And so I actually did high school in New Jersey, some of high school in New Jersey as a
Oh,
boarding
interesting.
student. And then I did college at the University of Pennsylvania in Philadelphia. Then in between college and medical school, I lived in Washington, D.C. for a year, and I worked at an adolescent health nonprofit. And I also, before that, over the summer, worked in Geneva at the World Health Organization in Switzerland. And then I went to med school at Yale, so lived in New Haven in Connecticut. And then after med school, moved to California for residency and lived in Palo Alto and went to Stanford and was there for 4 more years. And then I took my first job at WashU in St. Louis, so also hitting up the Midwest. And then now I'm in Tennessee. So I have chunks of time, like sort of 4 to 5 years, moved around, and has been a cool way to see healthcare and see the country, and has been kind of nice to do that, I think.
It also very much fits with kind of an explorer's mindset. And the
Hero journey.
yeah, you seem so curious about the world and people specifically. And I know it's some of the what I've read in the book that we're going to talk about later, but also some of the other interviews you've done. You talk so often about your curiosity with people. And so where was your favorite place?
Oh, see, that's hard. I think every place is good for different reasons. I don't think that I'm a weather person where I have to live in a certain weather, but I do prefer a light winter and a longer fall. I don't know that anywhere I've lived has been perfect weather-wise, but given a choice, I like as seasons and
Hmm.
less winter. I think New Haven was a lot for me for winter. It snowed a lot very regularly. Like one time we had to trudge through the snow to get to our rotations, and people were skiing, and that to me seemed like a turnoff. But every place was pretty different, and I was in really different phases of my life for all of them. So it's if you were go back to Philly now, I think Philly would be so different than college student Jessi in Philly, or med student. You're really confined to New Haven as a city around the campus, but you're not really exploring Connecticut very much because you're in school and rotations all the time. And so I think if I lived in some of these places again, it would be different. But I like them all for different reasons. And you're right about sort of exploring and people and stories. I mean, I was an anthropology major. I really just went in a psychiatry too because of that, wanting to learn more about people and their stories. And maybe that's the empath in me sort of like just being curious about what their feelings meant about them and wanting to know more. I have really close friendships too, which probably has to do with that. But I think getting to move and see how different places do different things, and, being really interested in systems and how systems work, getting to move and see different systems was also helpful, because how medicine functions in the Northeast, or higher ed functions in the Northeast versus the South versus the middle versus California, is all like, gets you the ability to sort of take pieces from different places and see where the strengths and the challenges are, and kind of grow from there too. So exploring in all sense of like the humans and the systems.
Yeah. I like the idea of thinking about kind of exploring systems, because when you first started saying that, my brain went to um uh, biopsychological systems, like the integration of like hearing and sight and cognition and the psychological. You were talking about like healthcare systems
Yeah.
and these more macro level, and it's so interesting because like talking about systems is can also be this projective test for someone. Like, what at what aperture are they seeing the world?
Mm-hmm.
Um
I see the world in all of it, which is really hard. So when you're a younger person who doesn't have power in what they're doing, seeing systems is frustrating, because you know that they could be better, but they're not being done in a better way, and you're in no place to change it. And I think that's a really hard place to be in. And I see that in a lot of the students I see, and a lot of the, as they are younger faculty too, where you're like, this is terrible. Why is it done this way? It needs to be done differently. And I was so into that way of thinking that I would try to change even the smallest things. Like, I probably went to 7 or 8 committees to change one form in residency, because I thought the form was stupid and a waste of everybody's time. And my friends were like, what are you doing? Like, this is, who cares? It's a form. We'll keep filling out the form. And I'm like, but it takes everybody like an extra 15, 20 minutes than it should. Like, that's not good use of people's time. And they're like, well, it's not a good use of your time to go to all these meetings. But I couldn't like deal, and so I did change it. And I'm sure that the one I made is still there, because no one would ever like then do more work to go to 75 committees to
no one
change it
cares that
again.
much. No one
No,
cares
right?
afterwards.
And like thinking like that, but then also thinking so much about the individual and the person within that system is really complicated. I think it makes looking at the world hard in some ways, because you're advocating for systems in in defense of the human. And I don't know that everybody does that. I think it's a very complicated thing of saying, like, I think a lot of people who get to systems levels are really interested in fixing the system for efficiency, for cost, but not maybe for the human. Or, like, I would not endorse something that would not directly help a person in their day to day life. And that is not something you'll see in a lot of people who care about systems or who are in leadership. And so it conflicts a lot, and like from a psychotherapeutic perspective is something I have to work on a lot individually, because it does like butt up a lot against each other.
Yeah, it makes me, hearing you talk makes me think of a person-centered approach to macro level systems, which we generally don't do. Yeah, especially in healthcare. I want to go back a
For
second.
sure. I
So
just
you're
tangential, like
no,
just went all off on a tangent, but yep,
we went on a tangent.
that's
We,
fair. That's like
um,
also you just therapize that turning into I and a we thing real quick.
right. Um, can you explain the difference between psychiatrist and a psychologist and a therapist? I mean, because I know for a lot of people, I think even people in healthcare may not really understand the difference. Can you maybe break
Sure.
down what those differences are?
Sure. I think it's really confusing, especially just the word therapist, because so many people use it, and it's like, well, what does that mean? And how many like years of school did you have to go to use that word? And Right now, if you ask social media, not a lot. So I think degrees really matter in understanding what that word means. And so when someone says they're a therapist, what did they train in and how long? So, most psychiatrists only use the word therapist if they're meaning that they like are not prescribing medication to that person too, or for some reason are doing more heavily therapy in the work that they're doing, which happens sometimes in private practice. But a psychiatrist, I went to medical school just like your surgeon or your OBGYN. And then instead of doing 4 years or 5 years or 6 years of surgical residency, I did 4 years of psychiatry residency, which means I did a specialty in psychiatry. And so I did inpatient psychiatry, outpatient psychiatry, consult in the hospital for people who are on other floors that have psychiatric related problems. So it's a lot on the med psych interface, probably more than any other sort of use of that term. We're also the as it stands right now, and hopefully would stay that way. But there's all sorts of different opinions on that. We are the only people who prescribe medication for psychiatric reasons, outside of primary care doctors who you might see, and they do that too. But we would be a specialist for that to see you for psychiatric medication. A therapist, a PhD, 6, 7 years of school, maybe a research degree, depending on if they do it that way, but maybe also a clinical psychology degree, longer focus on the like psychotherapy side, way more in depth. I learned psychotherapy in residency and I have had psychotherapy patients and I love psychotherapy, but I didn't take like 17 courses on it and see 100 and 200 hours of patients on it. Like that just wasn't where our focus was. Like we were seeing a lot of like ER psych and acute management of psychiatric illnesses. And so when you go see a therapist, they're more trained in a lot of the sort of nuances of psychotherapy, the different types of psychotherapy. You might see a therapist who specializes in different forms of psychotherapy for what you're experiencing. And I personally see a person who has a PsyD, which is a PhD with a clinical focus, and I do that because I had enough years of training that it helps me to see someone who has also had an equivalent amount of training in the thing that I'm getting help for. But some people are it's like go to training for a year or two, or a like clinical social worker, have a master's in counseling. It's just different training, like different time periods, and the difference for us being prescribing more than anything, I think.
Gotcha. Okay. Thank
Is
you.
that confusing?
Yeah. Yes.
You're like,
what
yes, it's still confusing.
No, no, I think it's so important. It's part of what I think we need to do as clinicians and healthcare providers is continue to educate people, regardless of audience size,
Yeah.
because there's just always another generation of kiddos or parents, people entering into the mental health, behavioral health world that don't know what any
Yeah.
of this means. And I think, and we will come back to this, but I see a lot of faculty have become first responders for college students, and faculty don't know these differences. And so I think it's really helpful for people to kind of hear it again and again and again, like what these differences are.
Yeah, I mean, I think when you're thinking like, well, when would I see a psychiatrist? I think, one, you're interested in meds for whatever reason. You wanted to talk about medication. Two, your primary care doctor wanted to start you on something or did, and it isn't working, and they want somebody to give you more of like an in-depth look at something. If you have like a medical psychiatric issue, so like let's say you have lupus and lupus is also making you depressed, it might be helpful to see a psychiatrist to look at like how your medications are combining and affecting your mood. Three, if your therapist, or four, even like if your therapist thinks you need medication too, like, you might work in where you still see your therapist, but you would see a psychiatrist too. That would be because sometimes like you're too depressed to even contribute in therapy, and getting a medication and starting a medication will make your ability to interact in therapy go up substantially. And so you might be told, hey, it would help if you consider medicine. Listen to them, they know what they're talking about, and they're referring you for something like that, and then we would be supporting while you would still get therapy. Severity might be a reason you might go right to a psychiatrist. So, the symptoms are interfering with your life so much that you're not doing the things you want to be doing, or you're functioning. If you have suicidal thoughts, maybe, but maybe you're a person with chronic suicidal thoughts. So that's a complicated thing to say, but that could be a thing. If you're worsening in a way that is like kind of getting too far ahead of you, where talking wouldn't be enough at this point, if you're coming out of a hospital or we're in a hospital, you probably should have a psychiatrist on board. And if you have either a personal past history with being on medication or seeing a psychiatrist, or your family does, that might also be a reason you might step right into it too. And I'll just say, like, no matter what, like, if you came to see me and I don't think you need meds, I will not give you meds. I will say, here, go to a therapist first and let's talk about it. Or, some psychiatrists might see you for just therapy alone. I don't, because I work in a place where that doesn't make sense insurance kind of coverage wise, and operating where I can be most helpful because of what I can contribute to the kind of culture. But I've never been like, take it anyway, you're here to see me, take the drug, right? Like, that's just not how I am. And I think a therapist also should, like, a good therapist should be able to say, I think you need medicine, like, you should consider that too, or you should start there and then come back to me. But, like, we're kind of supposed to both be like going back and forth in a way that helps you, because the chance that is less. Like, you shouldn't have to know. Like, you can guess, but you don't always know what's wrong with you. And so you should be allowed to rely on a professional and interprofessionals to say, this is what you need, or this is the best use of you, or this is how to start, or whatever it is. Like, that shouldn't always fall on the patient to know. It's just not fair.
Right. Well, and I'm going to reference your book a few times. Like
Sure.
in your book, you had several sections where you were being challenged by a provider, um, and and one of the things that struck me was almost like, yes, I'm a professional and I'm also a client, and your provider was saying, yeah, but maybe there's other stuff going on, and it sounded like he was trying to gently encourage you to see another perspective. And maybe, I mean, what I interpreted it as was, maybe don't trust your perception of what's going on, which is kind of crazy because as as clinicians, like, we are taught to encourage clients to trust their, trust their thoughts, feelings, and communicate them and be authentic. But um yeah, sometimes like our brain kind of messes with us. Yeah, and so
Yeah, I mean, I think it's hard, to be a therapist who sees therapists, but also, or a psychiatrist or anything like that, but also to be one who's in therapy. So
right.
I know that I'm a harder client, and in intake forms, I will say that. Like, I'll say, I'm not hard because of what's going on with me diagnostically. I'm hard because I know enough to be annoying. And I think that's fair. And I think we should have awareness of that. And I think it should be up to a therapist to take that on or not. Because if you don't want to deal with the fact that I know enough to be annoying, and that you might have to be a bit more creative, or you might have to dig into a well of things I don't know because I didn't go to 6 years of education on this, like, that's what I'm hoping for, and I put that up front because I don't want to make somebody feel uncomfortable or feel like they're trying to, like, live up to an expectation that is different because of what I'm coming in with, or almost trying to, like, feel like they deserve to have me as a client, which doesn't feel right to me. Like, I want them to be like, I like this challenge, or I like this population. I don't care that she's going to fight me sometimes on this stuff. Like, it is what it is. I'll fight her back in the end. And so I do put that up front, and I do think that we should, even if it doesn't ask occupation, because I do think that it makes a difference in the interaction, even if you don't mean to do it. So, like, me having an MD does its own thing too, but I just think that it's helpful to be like, this might be something that affects the client patient, or the client, like, therapist relationship. And you should just know that it's there, and that's something to know about going in.
Right, right. Thank you for sharing that. Um, I'd like to go back to the
Yep.
chief wellness officer role because, as you and I have talked about before, this is kind of a unique position. Um, can you talk a little bit about what that role is and maybe how unique it is? And then also like what a typical day and a typical week looks like for you.
Yeah. I mean, I think I'll just say, when I took the role, I was excited by the ability to help different groups from a systems level, like I was talking about. So, this role is unique in that you might have heard of some places having chief wellness officers, and they tend to be in hospital systems. That's where it originated. This role is in higher ed completely. So, I'm based in the line that goes to the president of the university for the system of Tennessee, which is all 5 campuses of the University of Tennessee. None of those campuses report to me. I do sort of like bring people together and have conversations and share ideas and get on the same page and then agree to work together. They don't have to do anything that I tell them because they do not report to me. And so it's a kind of interesting level of leadership that's really about the people and the people agreeing and supporting your ideas. But in my 5 campuses, one of them is a health science center. So that's unique in itself. Like some places might just have somebody who's just doing that. But I'm sort of looking at, well, how do they fit into the picture of these other campuses that have undergrad and grad students? And what does that look like? And so that is kind of cool of like a diverse population of people that are constituents or whatever word you want to use for that. And then, the like job itself is not so well defined that you could say, well, when you jump into this role, you're going to do this and then you're going to do this. And so what I've done for the first, like, I'll be at 2 years in February, is really try to understand like what we have, where are our strengths, where are our challenges, where could we work better together, where is there something where one campus is killing it and another campus needs help, and like how do we do better at like coming together and supporting that. And so that can be as like what sounds simple but is not, as aligning data collection methods, and can be as complex as like giving grants and seeing how little things pilot on different campuses and then whether you can expand them to the system, right? I think it is really a cool way to like think about the ways that wellness can be different in different cultures and schools, but also the same. So we have a big SEC school, like 30,000 students, and we also have a 1,500 student rural school that was formerly Methodist. So they're very different cultures about wellness and mental health. And yet I'm tasked with sort of saying like, well, what should you expect if you come on any of our campuses? And where are we alike and where can we like support each other in our differences? It's kind of like a interesting way of using anthropology plus medicine to sort of
Yeah.
look at what's going on and make change and try to make system lasting change. And I'm not a shiny object person, so I think a lot of people might come into a role like this, smile and wave and buy something. I don't believe in that because I don't think that's ever the answer. So I like the hard stuff. Like, how do you get in there and make a difference and make it lasting, even if it's less like sexy and not shiny objecty? And what does my day look like? I have a lot of Zoom meetings. So we have people across the whole state, and the state is much longer than you'd realize. I don't think we learned Tennessee geography in school well. And I think it can take, from where I am in Memphis, where I still see patients, which I should emphasize. And that was a choice. I see it can take about 6 hours or 6.5 hours to drive to Knoxville, which is where the system is really based. And so it's a big state. And so a lot of meetings that happen over Zoom, but also a lot of travel. I think people who are in the Memphis office would probably say they see me, I don't know, once every 2 weeks or something, that I'm always somewhere. So giving talks, or like just this past week, I talked to the retreat for Office of General Counsel, the retreat for audit and compliance. I went to a meeting for all the student health directors of Tennessee. So, it's kind of varied where I'm like spending my time and what I'm doing, but, uniting people and collaborating is the most fun and is where I like to spend my time.
One thing that I I really like about Tennessee is how geographically diverse it is because you go from the that Mississippi plains river basin and you've got the mountains on the eastern side and yeah there's it's just such an I think it's a beautiful state. I'm very jealous. I wonder like how much of what you do either trickles down or is kind of surgically like a focus in terms of s- um the student experience. Because I know ultimately, you know, the University of Tennessee is there for educating students.
Mm.
um but I think there are plenty of kind of administrative like roles that really don't have a direct impact on students. And I'm thinking about like I was just talking with someone about like if they could put energy into one thing, what it would be, and they said orientation. Like they
Mm.
wish that orientation was different. And I wonder like yeah, I wonder like how your work ultimately works its way down to undergraduates because like you said, you're at a macro level. You're systems level. You've got all these campuses. But yeah. How does it work all the way down to students and maybe even their parents too?
Yep. So I think the thing that maybe people don't realize when we think about people advancing through college and recruitment and retention, especially retention, that like number one and two reasons people don't keep going is like finances, which shouldn't surprise people, and mental health. And so it is not a small problem, it's a big one. So if you're concerned about like enrollment and increasing enrollment and then having people get through college and then the value of a college degree and all of these things that come up. I think that what people don't realize when you think about the student experience is we're always really concerned with getting people to come to the school and then getting people to finish the school. And if you look at the data, the top two reasons people don't finish are finances, which you could agree also impacts well-being, but the second is mental health. And so it's not just like a thing we talk about to talk about it, which I think sometimes even in the workplace, people think that we're just talking about this stuff to talk about it. We're talking about this stuff because it has real outcomes, that people are not finishing school as a result of this at high levels. And so you can't look at the student experience without including wellness. Belonging is part of wellness, and that's a big key thing that people are not experiencing on campuses that they should be getting out of a campus experience, especially the idea that like how many people are experiencing loneliness. That's something that we should be looking at too. I think that, for me, the student experience is a well student experience. And so it comes from as early as like transitioning onto the campus. But, I think it's something that we can't just do at the beginning and you have to do throughout. And you have to also transition them into the workplace in a well space. Like, I think if I learned more of those skills in college, I think I would have approached grad school differently and the workplace differently. And I think that's an important thing to think about is like we are preparing people for the workforce and jobs. Like that's where college and higher ed sometimes gets a ding is people say, well, what is it doing? And a lot of people are being prepared for the workforce and we have to think about that. And some of that is like, how do you listen to people and support people and be an emotional, like how do you deal with your emotions when you have them and you're also working and also in school and also not sleeping and whatever, right? And all of those things go into being a successful human in the world just as much as, I don't know, like class does.
Um, do you all have data on, or, and maybe it's just kind of more informal. What is the toughest year for
Mm.
students at either like all campuses kind of averaged out, or let's say like, you know, UT, like Knoxville, where are students dropping off or fading I
Yeah.
hear a lot of fading happening at a lot of universities.
Yeah, I mean, I don't know all that data off the top of my head, and I think traditionally colleges have really only measured first to second year like retention, and that's been the number that people are looking at. But I
Hmm.
think if you talk to people in student success, they're really interested in year to year and how that's changing instead of just that one number. Like it used to be, oh, all this many freshmen get to be like sophomores, good for us. And that's still a number that I think people are looking at, but they want to be looking at every year and not just that. And so I think, I don't know all those numbers off the top of my head, and they fall more in the student success arena than necessarily always in mine. I think for ours, we probably compound a lot of the variables in a lot of ways without clear data as to how. But I think it is really important for people to look at the year to year and not just the first to second. I think that we do a lot for freshmen. And I think because of, maybe data in the past that suggests freshmen and the transition as a freshman was the hardest, there was a lot put into the first year experience and sort of transitioning them to campus, and resources on campus were probably less after that. And I think people are realizing that now too, that like good for that one beginning stuff, but what about like coaching along the way? And so I think that's been something that I know some of our bigger schools have been piloting with advising and sort of support services, like make sure that they're there the whole time and not just in that transition year. I think transfer students are also in an interesting space, right, where they can come from wherever with whatever in whatever year, and probably don't get that nice onboarding that you do as a freshman. And so I think there are these places that you could look at as sort of risk spaces and try to target them, but also be mindful that like it's a whole process, and like you could as much say that it's hard for a freshman as you could say around exams and the winter time is worse for people, right? So I think it's just being mindful that all of these things sort of intersect to create people's well-being. And it could be year, it could be the timing of tests, it could be the kind of classes they're in, it could be winter just because it's winter, and all of those things kind of coalesce to make the whole student experience.
Right. Can um can you talk a little bit about CAPS and what CAPS is? You and I've talked about this a little bit before, but and then how I don't want to ask like how well UT manages like counseling services for students, but what University of Tennessee does in terms of how to support students with mental health, behavioral health, and let's even include substance use, which that's a like a growing support mechanism on a lot of campuses.
Yeah. So for your latter point, I'll say 30% of students are like coming in recovery. Like that's a big proportion of
Is,
students.
is that the entire UT system
That's
or
like that's like where we're also comparing to national data too, I think.
wow?
They're big numbers. And I think some of it is you'll see that people will talk about being sober, but they're not, they're California sober. And that's a different conversation. But students are definitely drinking less or coming in recovery or choosing to be sober. And that difference does shift the population and how you think about supporting them and what you need to be doing to support them. And so that is an important population at risk, but also that needs peer support programs and on-campus groups and other activities that don't involve alcohol and all that kind of stuff. And so that's a really important thing to keep in mind. I think, your question, so counseling and psychological services is what most people call like CAPS, or, some places it's just like student counseling center or whatever. um, every campus in the whole country is strapped when it comes to student counseling. I think, long before the pandemic, it was like, we are in a mental health crisis. We can't see all these people. How are we supposed to see all these people? And, college counseling centers shifted to short term care because of that to keep up with the demand, right? So, short term meaning 5 to 8 sessions, maybe once a month at most. To see people for an issue or two to try to help support you and get you back to school, but not like as somebody who has PTSD who needs to be seen every week. And so big referral networks, less people that are regularly seen on campus is sort of how I would describe on campus therapy. If you're coming into college already going to a therapist, don't go to your on campus one. But, you know, it's free. So that's a big benefit, I think, for folks. And so they do some like want to take advantage of that no matter what. But I think it's the kind of thing where we're never going to counsel our way out of this problem. We have to think about prevention. We have to think about external resources that are bolstering our internal ones. We have to think about telehealth and how that complements things. And I think we're all looking at different ways like that to help. I think, you know, some of our counseling centers have done some creative triaging process with crisis appointments and how to support when people just need basic needs support instead of like actually counseling and getting them to the right place. Because kind of like we were talking about before, like when you just have a lot going on and you're stressed about everything, like, well, do you need to talk to the financial people? Do you need to talk to the mental health people? Do you need to talk to the people who can get you food? Do you need, like, what do you actually need, and who's the right person to talk to is a hard thing to figure out. And so, like, you know, triaging more upfront can be quite helpful for that. But it's definitely a challenge on campuses to fully support the need and figure out how to support the growing need, which has only gotten worse post pandemic.
Gotcha. What do you think the UT system does particularly well in terms of mental health, substance use support for students,
Yeah.
and maybe even faculty? Let's include faculty in it because some universities are doing a fantastic job of even having like faculty and staff supports.
Yeah. So, I mean, I think that I haven't met a person who doesn't love their job and care about the people, which I think is true on most campuses, but it is particularly true here. I think college counseling centers can get a bad reputation because the people just are mad at wait lists or whatever, but always the people who choose to work there are choosing to be underpaid and overworked because they like the population. And I think that's something to always keep in mind. I think that we, in terms of substance use, have been, you know, some of our campuses do it better than others, and so we've been using the ones that do as like a guide to grow what we do on the other one. So in terms of a peer support network, but also in terms of Narcan availability and Narcan training. You know, when people come in recovery, they're also at most risk of overdose because they might use a higher uh, like a higher amount than they should because that's what they used to be able to use. And so they're at more risk of something like that. And having Narcan, which is a reversal agent for an opioid overdose, more available on campus is a big push of me. And so I think we've been working really hard to do that in our campuses across the state. Um, you know, I think that there's probably not anything like super novel that we're doing on the one-on-one. You know, I think some of our triaging in some of the campuses is kind of cool. But I do just think, you know, we're all supporting very different populations, and that's kind of interesting too, like how we contract with telehealth to support it, or how we contract with local providers, or if there aren't local providers, being mindful about what is available in the state that's virtual, I think has been something that we've had to do because of just like some of our places are quite rural and there's just not a lot of people working there.
Right.
And recruiting to them is hard too. And so I think being really mindful that like just because you go to a school that's in a rural area does not mean you don't have access to care is really important and central to how we think about this stuff.
How do you think the the symptoms, the diagnoses of what students are bringing in or what they develop over their undergrad or graduate experience, how has that changed? And I know you've been in the wellness officer position for 2 years in February, I think you said. But I mean, you've been around students for a while. Yeah, how have things changed, and how have things stayed the same? Do you think?
Yeah, I mean, I think, you know, which would be the case in almost any group, anxiety and depression are like at the forefront of what we see always and always would be. I think that you're seeing um, some difference in how things are talked about in the context of social media. So I think that there are people who show up in my office that are pretty convinced they have diagnoses because they saw them on TikTok. And I think that there are pluses and minuses to that. I think people should have access to that information and should be learning, but should be learning with a kind of skeptical eye and also bringing that in with them to talk to an expert. So I think I have this because I saw this video and this video said this. What do you think? And like being open to what they think, not being what the TikTok said, is important. I think we've been seeing an increase in desire for ADHD diagnoses as a result of that, but concentration can definitely be lots of things. I think we've seen an increase in like sort of desire for autism diagnoses due to lack of like feeling socially connected and maybe not knowing how to interact socially as much, but sometimes that social anxiety, sometimes it is autism. But I think that like, having the awareness that sometimes you see a 15-second video and it might not be everything is important. A lot of discussion, more open discussion of trauma, I think, in students coming in students experiencing things on campus, in students exiting into the world. Um, there's definitely more of a focus, with Title IX and things like that, at like trying to decrease the numbers on the of like assaults on campus. That it was a big thing for a really long time, and I think it continues to be a big thing. I think with the pandemic and with social media, I mentioned social connection. I think that's a big thing. I don't think, and AI probably isn't helping either, like with people feeling like they need to even like get out of their rooms and talk to people, and then they just don't have a lot of experience with it. And so, I hear a lot from folks that like people don't know how to talk to people, and also that people don't know how to regulate their emotions, and they go really quickly from like 0 to 100 and don't know what they mean, but want a diagnosis again because of TikTok. Like, I'm sad, so that must mean I have depression. It's not always true. You could just be sad. And I think that's important too. But I don't know that like what they're seeing as so much changed as like some of the things and factors leading to it might have changed a little bit. Perfectionism, school stresses, all of that always a problem in college. Sleep always a problem in college. Identity development always a problem in college. Substance use and experimentation always a problem in college, but definitely has like, shifted over time what that might look like. A lot more marijuana, again, sort of California sober, than alcohol, probably even for me when I was in college. Yeah. Does that answer your question?
No, yeah, absolutely. It's also I really like asking folks around the country that question because sometimes I'll hear people respond with like more of a diagnostic focus. Other times it's more of a gender breakdown
Mm.
where some people will talk about, oh, guys really are not doing well. Women are crushing it and guys are doing terrible. And so,
Mm.
yeah,
I think there's that conversation. I think I see more women, but I don't
mm,
know if they are just seeking more help or defining it more or what that is. I don't know if it means that there's an inequity of need, but I do think that like probably getting the guys to go to a psychiatrist is more complicated, maybe. But maybe not for every female either. I don't want to overgeneralize.
right.
Um, yeah.
So as a psychiatrist, I'd like to talk about medication. And I don't want to ask too broad a question because, well, that's just pretty lame. Like, how do you feel about medication? But students come to you with TikTok video or something on social media that they've seen or heard, and it's much more common now for people to ask for specific medications, especially since whatever that law that was passed like decades ago where
Where they can't
pharmaceutical,
advertise.
yeah. And I wonder like what what do you think is the most effective strategy for college students in terms of medication? Is it going slowly onboarding medications? Is it focusing on behavioral change first and then coming back for medications? And obviously this is dependent on like what the diagnosis is or the what the symptoms look like. But I mean, how do you think about medication in terms of how you frame these conversations with students, knowing that like sometimes like you may have two meetings with them and they may disappear, and they may disappear with a script in hand.
Yeah. Let's stick with anxiety and depression, or because I think I'm gonna 100% tell you if you have bipolar, you should be on medicine, and if you have psychosis, you should be on medicine. Um, much to whoever out there is gonna get mad at me for saying that, but you can be a functional person and stay in college with those symptoms if you take medication. So I think that that would always be my argument. Does that mean I will always win that argument with students or something? No, but that would be my argument with those particular diagnoses. I think if you're thinking about anxiety and depression, it really matters like how much it's interfering with your life, and the things that you want to be doing. If it just started bothering you and you can function mostly, I might say, like, start with behavioral stuff, start with therapy, start with that. If like you haven't left your room, or you can't take a test, or you can't like sit through, I don't know, a class, like that's a different story. Like you have stuff you need to do and you're not doing it, and you're not doing it well, and you could talk all you want in therapy, but it's going to take some time, and so will meds. I think it's really important to note that our meds are imperfect, that they take a long time to work, that we don't have personalized medicine, and that like I can tell you exactly based on what you say, this is the only med that will work and that's the best one, and try that. Like it's just not like that. You said if somebody comes in with a med, I might ask them why they heard about it and what they liked about it, and I bet you the med is on my list anyway, and sometimes I will just agree to let them try that one if they want to try it. It depends. If it's like not for the thing they come in with, that's a whole different
Right.
story. But if they're like, I have anxiety, my friend takes this for anxiety, and it would have been one of the three antidepressants I would have recommended, I'd be like, do you want to take the one your friend takes and see if that works? I don't have a problem with it. Like, what's the difference? There's no,
Right.
a lot of things which can tell in my book too, a lot of things with psychiatric medication requires buy-in and people being on board, and if you don't believe in it, or you don't feel listened to about it, or you don't think you had a choice in it, like it's going to be a very different situation. So you get a choice to take a med or not. Like, so if the med you're going to take is the med your best friend takes, like if it makes sense and it's not like I'm giving you something completely inappropriate, sure, I might consider that into the thought process. Like maybe they'll be more likely to take it because their best friend takes it too. Is there a
Right.
reason why that one isn't a good drug for them, right? Like I will put that into my sort of algorithmic thought process around giving someone something. Genetically, if sometimes if something works for a parent or something, it might work for you. So that's also of note. But I think I try to think about, especially in college students, the things that most come up are side effects around weight gain,
Mm.
um, side effects where you sleep too much. So if like you need to be in class a lot, or a med might make you hungover in the morning if you take it at night, also important. If it's a more than one time a day medication, good luck. They might remember, but they're gonna have a hard enough time remembering they're supposed to take one. So I think a lot of those things come into play, that also might come into play for someone who sees a child and adolescent psychiatry,
Hmm.
because I'm thinking a lot more about like what are they gonna get mad at. So if they gained weight, if that's the only choice based on what they're experiencing is a med that has that as a side effect, I just have to talk to them about it. But if that isn't a choice, if that's a way to avoid that, body image is huge in college students, male and female. So recognizing that that could be a reason someone stops it. Sexual side effects too, right? So like most of them have a risk of that, but it's an important conversation to have in this population, because they might go like, ew, like get this away from me, I don't want this. But you could say like it might be better in like a week, just give it a week, right? And like if they expect it, then they don't feel lied to. So like trying to think about the things that might cause somebody to stop taking their med as a college student are really important. Drinking on it, can I drink on it? All those kind of things I think are really worth considering when you see this population more than any other population. Like, what are the things, again, for buy-in that would make them stop? Like, you should know that and you should be prepared. And I will have open stigma conversations too. Like, what have you heard about meds? What are they like? What did like you see on TikTok about medication? What do you hear about psychiatry? What scares you about this? Like, people don't like meds like for anything, but a college student tends to, most college students don't have chronic illnesses. Like some of them might, but it's going to be rare, and so they're not taking meds for anything. So having to take a med at all is a new process. So much so that like they don't understand refills and my meds will run out and they're like, but they were empty. And you're like, it's not an antibiotic, like you have to go get more. And they just don't know because they never took a medication before, you know. And so just being mindful that if you've never taken a medication before, it's scary to start a medicine, and for sure scary if it like could alter your personality, which I think they worry a lot about, which it doesn't. But it's important to have that conversation, and also important to have the conversation about like, well, do I have to be on this forever, right? So all of those things, I think it was a long-winded answer, but when I'm thinking about meds in this population, I think about side effects that might primarily affect them, how to get them on board, how to have the open conversations up front so that they don't feel like something like, they decide to just throw it away and not come back. I'd rather, if you didn't like it, that you told me you didn't like it and we have a conversation and you can, you know?
Um, the conversation around medication also makes me think about pre-med students and business school students, basically kind of these programs that have a self-selection effect of like type A students. And in the book, we you talked about perfectionism, and I really appreciated that kind of the distinction between the two types of perfectionism. And I wonder if you see type A students that have perfectionism and they view medication, some of the amphetamines, as being performance enhancing. Because I know that I've seen that at some of the business schools, especially where students feel like they need every edge because it's such shark infested waters, even
Yeah.
in undergrad.
Yeah, I think it's interesting. So, healthcare workers do not see it that way. Healthcare workers think that it's going to get them in trouble for being on drugs. So, they
Interesting.
don't really see it as performance enhancing. And so, they have a lot of hesitation taking the ones that they're already on and taking new ones. So, like, as a person who sees a lot of healthcare workers, it does not get sent like that.
So that's
Uh,
similar to pilots. That's similar. Pilots have a fear of that same thing.
Yeah, and I think it's like, obviously if you're on a med and you're prescribed a med, like you are allowed to have a positive drug test in that setting, right? Like that's what you're positive for. But I think there's just fear of that, and fear that somebody else is going to judge them for being on it for the same reason and think that they're like an impaired physician as a result. So in healthcare, people, there's just like a global dislike of the idea of it. It's not seen as performance enhancing, but I think in college students, sometimes it comes from parents that, like,
Hmm.
like, oh, I took this when I was younger and it helped. Or my parents said, well, maybe it's ADHD, go talk to a doctor, right? And so I think most college counseling and college psychiatry teams like have a lot of rules around new diagnosis of ADHD in college for that reason. Or like maybe you have to get neuropsych testing, even though it's just a hoop and an expensive one. Or maybe you need 5 years of records to show you've been on it your whole life, not because we think people are lying, but it just is more sort of like long term proof that it's the right decision in a context where people might just be asking for it for performance enhancing. I've never seen it. I don't have patients that are really doing that. I might be just overly trusting and nice, but I really feel like the people who end up in my office, like I think I have new ADHD. It's like their mom used to do all this stuff for them and their mom's not there anymore and they didn't even
Right.
realize their mom did all that stuff. Or like, colleges like midterms, finals, you have to like keep up until midterms. Like you don't have a million little tests and assignments and stuff. And so I think it's really easy for things to kind of come out later in that setting. And I think they're not lying for the most part,
Right.
in my experience. But I do think it makes campuses kind of concerned. So they have a lot of hesitation around how they prescribe and all that. And I understand that, having worked on 4 different campuses as a psychiatrist at this point. It's similar across the board. It's just like they maybe had a meeting and all decided that's what they were going to do. That's okay. But I definitely don't see people asking for it. But I do think the opposite about other meds too. Like if you're a perfectionist, I think people see needing a medication as a failure, like in that sense. Like I
Right.
can't just do this. Why can't I just do this? Why can't I just feel better? I just need to feel better. Everyone else feels better. Why don't I feel better? Or, you look at your workplace and you say like, everyone looks miserable, but why am I the most miserable? Or why do I need help to not be miserable? Right. And so I think people can wait a long time to get help mental health med wise because they kind of look around and everyone else seems to be dealing with it without it. Or maybe they're not, but they're not talking about it. And so meds are seen as like a last resort or like a, ugh, like, fine, I need meds or there's no other answer at this point. Like it's like, that's it, you know? And I wish people wouldn't see it that way because it doesn't need to be like my healthcare worker patients always say, like, I haven't hurt anyone yet, which I think is like the most terrible explanation for how long they wait to get help. But, I think that they shouldn't be viewed like a failure. I think they should be viewed more like glasses or high blood pressure medicine, but we're not there yet. And so I think people have a belief that if you need something like that, something's wrong with you or you don't deserve to be here. And, here, not necessarily the world, but here, like in school or whatever. And that is a misconception that we have to work on to fix, especially with perfectionists.
Um, what happens when parents reach out? Because that's a topic that I'm particularly interested in. Um, Specifically around FERPA and HIPAA,
Mm.
the two laws protecting education information and healthcare information. Um, how do you deal with that? And I know that like you have this macro level role and
Yeah.
everything, but how do clinicians at UT handle that? Because I view college as this precarious time where all these kids are over 18. They sound like adults, they smell like adults, they look like adults, but developmentally they're not always making decisions like adults, and maybe even neurologically they're not really all that adult. How do you all talk about it? And I mean, the law is the law, but how do you all frame that?
Yeah, I mean, I can talk more about me than any sort of other clinicians or how we do it systematically because I don't know that we don't have a system process for that. But as I've always felt like as a clinician that they need to be explained things a lot. So I will often say, I am not able to talk to anybody that you would want me to talk to unless you give me permission. I would like to not have to wait to do that until it's an emergency. What does that look like for you? What would you be comfortable with me sharing with a friend, a family member, whatever, whoever that person is? One of the things I wish we like, that I try to even get out of patients is like, I don't want to tell them what you're telling me. I just want to tell them that you're here. Like, and like, can that be a separate consent? And we talk about that sometimes in what you're saying, sort of this FERPA HIPAA overlap, where there's a care team on campus and it's made of like people who are teachers, people who are police, people, right? All these different things. And they're meeting about students of concern. And then the students of concern place, like a dean's office says, like, well, is this person getting therapy? But if the student didn't consent, you can't really say, yeah, I see them as a patient, right? And so, I think we do need to think about how we talk to people about consent so that, you could consent to me disclosing everything if that's fine with you, but you also could consent to me just saying you're here and if anybody asks, and that's just simple, like, you are getting the treatment you were asked to get or whatever it is. And so I talk to students about that up front. I think it's important to not make the assumption that that's their parent. I think, for me, I see a lot of nursing med students, they're even later, right? 25, 26, 27. They mostly don't want parents
Right.
involved. I think it's also important that if a student like rejects involvement of anybody, that if it's about stigma, you kind of work on that for a while. I don't ever call a parent unless I need to call a parent. But, there are definitely parents that try to call you. Less so in my current job than my previous job. When I was the psychiatrist on the college campus, I got calls from parents all the time. And like sometimes I would just tell the student, like, hey, your parents called 5 times. I can't call them back. Would you like me to? Just to say, just to listen or whatever, just to get them off all of our backs,
Right.
and
Right.
and then sometimes they'll be like, yeah, sure, like just don't tell them everything. Or I had a student who was like very anxious and like couldn't remember stuff in the appointment and would ask me to email the like plan to her and her mom, and then they could look at it together and talk about it. Like, if that's how you better function and you have a relationship with your parent like that or whoever, like that's fine, but that's up to you. So I think all of those things need to be sort of like talked about, especially over time as you develop a relationship, and not just like blanketly refused up front and never dealt with again, but then also not just assumed it's all or nothing. And I think that that's scary to people. So I also, right, seeing healthcare workers, like if you needed off for school or something, they don't really want to be off for psychiatric reasons or like a meeting or whatever. So like I'll also be like, if I write the note, they can look up my name and etc. Is that really what you want, or you just want to like show up an hour late and deal with it? Or like we have conversations like that are really open. Or like if I write a note to a program because they asked me to, I let them read the wording and say, no, they don't want that in it. Does it have to be in it? Are you sure it has to be in it? And we kind of go back and forth that way so it feels fair, instead of just like, you asked me to write you a note for school, I'm going to write whatever the heck I want and you just deal with that, right? Like it's not, I don't practice like that. I'm pretty transparent. I think that consent and all of that is not all or nothing, and including the person in the decision and how it's conveyed is really important. Obviously, it's different in an emergency, and they don't have a choice anymore. But I think that the more open with them upfront about a lot of that stuff, the more they'll be open about it coming out as they get worse. Like sometimes I'll be like, "Listen, like I know you didn't want to talk to your mom like 4 weeks ago, but like it doesn't seem like things are going in the right direction, and I'm a little worried you might need time off school. Are you sure you don't want to just like broach this topic together with her over the phone, so that like when you have to have that conversation, if you have to have that conversation, it's not a shock?" And sometimes they feel more on board with stuff like that.
I really appreciate that approach because I think there are a lot of universities and colleges have, in what is in my opinion a very obtuse blanket policy of, we don't acknowledge parents existing except when they're paying the bills. And I don't think it's a moral or ethical issue. I really see it as a practical issue because they are part of the treatment team, or at least I think they should be.
Yeah.
Um, I also like what you're saying because you didn't explicitly say this, but reading between the lines, talking about the release of information, you are turning it into a therapeutic material. Um, it seems like an opportunity, like, hey, tell me more about like what's going on here, like, because I mean, the clinician in the back of my head is asking like, oh, this could be an avoidance strategy, like what are you avoiding? And it seems like you have a really great way of approaching that without calling it out explicitly.
Yeah, because I mean, I think everything that you have to do has to be part of like an opportunity to learn more, right? So like if I have to do a contract for ADHD meds because my clinic says so, I'm going to talk through the things that might make them uncomfortable, or the fact that it says I could maybe drug test them, right? Like these things that like I'm just curious how they feel about some of these things, right? This is another thing that you might just need to do, right? And I think it's important that you're not just like assuming anything. And
Right.
if somebody doesn't want to talk to their parents, that's important. But if somebody wants to talk to their sister or their best friend, that's also interesting. Like, why is it that person? And why, like, how did that person get to be that person? And, you can learn a lot that way. Even if you ask your friend, like, who their in case of emergency is, you would learn a lot. And I think, understanding comfort level with people knowing also can help with, for me, for medication. If you go home and you have a bottle, is your bottle getting thrown away? I've had that happen. I've had patients put their meds in Advil bottles and stuff so they don't like get in trouble. Like if that's what you're going home to and you're terrified for them to know because they won't understand or culturally won't understand. I need to know that's what I'm getting into, because the fact that that person even put a pill in their mouth is like 100 steps in advancement of their cultural beliefs around mental health. And so, like, I think that can be really useful to know too, I think, as a barrier for someone to stop, right? If you go home and they find out and then they say, well, what's wrong with you, suck it up, you like, that's terrible, it doesn't do anything, it just like you're going to get addicted to it, whatever, like kind of gross like misconception and stigma comes up in your household, you might listen because they're your parents. So even though you know it's true, like, and that's what scares you about it, like tangibly being told that stuff is very different. And so, like, having those conversations, even just to know, like, what am I getting into in terms of family dynamics, especially around meds and the culture around medicine, is like super important to people continuing meds. And like anybody who talks about meds without recognizing all of the dynamics that it takes for somebody to take a med is not doing their job appropriately, because um taking medicine is not guaranteed. Any kind of medicine, diabetes medicine, right? Like people not regularly taking their medicine for something like diabetes is going to end up in the hospital. And it happens all the time. Like half of the medical floor is people who are not taking their diabetes meds, whether it's expensive and they can't afford it, or they just don't see the point. I don't want to inject myself with that. Well, I have to do that, right? And so that's a big part of medicine in general, like getting people to understand why. And like vaccination, I don't even have to get on that conversation, but all of these things are like, how do you understand what's being said, what you believe, and based on evidence, and how to have that conversation to get on the same team about something. And it doesn't always happen. I definitely have people where I will write notes and I'm like, discussed like being on this medication, patient feels X, Y, or Z, is not ready to be on something. They know that if they get worse in the following 4 ways, that they should come back to me, and I hope that they will, right? Like that's what I write a note about. Happens all the time with bipolar patients. Like, I wish that mania wasn't fun. It is fun because you do stuff and feel good and don't remember all of the bad stuff you did. So you do not want meds until you're depressed. And I get it. But, I have to have that conversation all the time from like a risk perspective, but also just from like this is what's right, but you're not going to get there yet. And so I try to get to a place where that's true. I mean, the best conversation I could have about that, when I was in residency, we had all these young folks who had new onset psychosis getting admitted to the hospital.
Mm.
And they all had the same attending. And I was a first year resident, and I called the attending and I said, like, what are you doing to these people? Like, why, what's wrong with your patients right now? Right? Like, just kind of curious. And he said, well, like, Jessi, part of my job is just to be a place that they can be seen until they want to take medication. Some of them are going to get worse before they get better, and you just happen to have all of them right now. But I'm not doing my job. In fact, I am doing my job, that they even will say I'm their doctor. And it was
Wow.
like,
Yeah.
for me, because I was like, why would you see someone that like you're not, that don't, like, how long can you see someone when you're not actually helping in the way that you think you can help? And he was like, the point is, when they know that they need it, they know they can ask me. And I don't know, like that's always really stuck with me as like a way to think about meds and to think about our role and to think about how linked to a human it is.
Right. I think that uh, yeah, I love your description of kind of your approach with medication and how you talk about it, and I also appreciate talking about the FERPA and HIPAA, and it makes me think about the larger category of intervention and how I think in mental health, like we don't really, I don't think we take ourselves very seriously because I don't think we view ourselves as healthcare professionals very often. DBT, like whenever I'm doing DBT with someone, I give a warning label that, okay, here's the problem. You're going to change, but you're going to go back into an environment where no one else does. And so when you talked about the cultural aspect of medication,
Mm-hmm.
I was thinking about clients I've worked with who learned DBT skills and they went home and to like a family in Jersey and the dad was like, get that shit out of here.
Yeah.
like I don't want to hear your I statements.
Yeah.
like yeah, and so I think that interventions in general, like I think we need to think more cautiously about why are people accepting these interventions, but more importantly, why are they not accepting them, and what are some of the barriers and the costs if they do accept them or use them? Um, yeah, I think that's interesting. Can we talk about your book for a little bit now?
Sure.
I've referenced it a few times. Um, how do you feel? Okay, let me hold. You've got it in the background. I got it right here. where did the title come from? Because I think you and I like we probably asked that question many times throughout a week, or in our work lives. But of all the titles for a book, why that one?
Yeah, I mean, one, I like book titles with questions. That's one thought. But also, because I'm curious, you already said that. But one of the things I really realized in helping professions is we spend a lot of time asking other people, but we never ask ourselves. And I had never asked myself. And so, I think how are you really is similar, but really it's like how do I feel? Not how do you feel, but we spend so much time asking you. And so I think that's where it sort of, came from was like, but no, but what about me? Like you're a human too, or like in the meta sense as a person who sees healthcare workers, same, right? Like my patients also aren't doing that. And so being just really mindful that like all these people that caregive for other people, therapists, like teachers, caregivers, parents, you spend so much time just being like, oh, you're crying. What? Like, how come? Like, not how does that then impact me or anything like that. And so the lens, the reverse lens is the part that sort of stood out.
Um, early on in your book, and I'm not going to get this perfectly. Um, I think it was one of your classes in med school, and everyone was going around, and everyone was, I'm going to use my terms, not yours, kind of virtue signaling, like everyone wants to be a neurosurgeon or whatever. And I think you made a statement like, I'm not even sure if I want to be a doctor. Is that, did I
A
get that
hundred
pretty?
percent right. Uh huh.
Oh, okay. So the mad cow disease is not setting in yet. Excellent.
No,
Okay.
no. It's
Um,
always hard to explain classes in med school, like, because it's really like a second year seminar, like, but it's just like whatever. It's class. It's fine.
first of all, I was so curious about like how did you how are you able to say that? Because I'm thinking about being in grad school and being vulnerable, transparent, and I was with a bunch of other like burgeoning therapists, so that's the safest place to do that kind of thing. And I think that would have felt like really awkward being in med school around like doctors and saying like, yeah, I'm not even sure if I want to be here. Like, yeah, I mean, it's probably been a few years, but like, how did you how did you come up with that response? And yeah, where did it come from?
I like wonder in a way if I like didn't think about it as much as I should have. Like I knew that it was like facetious and that it was like a little bit of like a dig that I don't know if I realized like how much that was true about my actual lived experience when I said it. Like reflecting in the way I write about it, you can tell that it was like in my head and I was thinking about it, but I don't know if like when I said it that I was really like holy I just said, like, I don't know if I want to be a doctor in front of a bunch of people who have been one upping each other for an hour. Like, I think I realized that after I said it. Like, when I said it, I think I was like listening to all these people and they were like annoying me. And I sort of have like a biting, sort of cynical, sarcastic sense of humor and a little dark. And I think I just sort of like was sick of that, like, thing that they do, and I was like
Right.
what's an answer that's just gonna push them, and like is just gonna push them over, that is also true enough to me that it'll feel right saying. And then I said it, and then I was like, and they looked at their faces and I was like, oh, like nobody really laughed, and I don't know if I expected them to laugh, but I like I don't know. I kind of was hoping that somebody, I think I probably thought somebody would be like, Jessi, of course you said that, and instead they were all like, oh no, that's contagious. Keep it away from me. Like, I don't want that doubt and whatever. But it was so true to my like actual experience. I just really hadn't said it out loud. And so I think it's almost like my sort of like irreverence took over in a sense that like didn't even realize how deep I was being until later, and like how true that was until later. But it was so true. I was like crying to family members, being like, why am I here? Like, this is terrible. Why am I doing this? And like, I just hadn't like put it all together in a way that was like meaningful until sort of I just did that and then was like, oops, like
Yeah.
that was a bigger thing than I thought.
No, I thought it was so interesting. And I think it's very easy to just kind of like read past that. And it was just this little line, but it stood out like very contrarian, little like ODD. But yeah, I just thought it was so interesting because it was almost this like this authenticity erupted from somewhere. And correct me if I'm wrong, your dad was a psychiatrist, right?
Yeah, and over time the amount of medical people in my family has just gotten worse. Like my sister is also a doctor. She switched careers from working on Wall Street. My brother's married to a doctor, my other brother's married to a nurse, and my sister's also married to a doctor. So
They're
it's just
everywhere.
gotten like
They're just everywhere.
everywhere. But at the time, yeah, my dad was a psychiatrist. He didn't see patients, but he did research and sort of translational research to business and academics. And yeah, I mean, it was an interesting thing, sort of like you do science, you're good at science, you're smart, you be a doctor. And I hadn't really ever thought about it. And sometimes I think I didn't really think about it until like, I don't know, now, like before now, but like, I think a lot, I see that so often in my patients too. It's just like, you don't really have time to question it. And every time you do question it, like the response you get is so weird. Like in college, it's like either, well, quit, you don't deserve it. And then as a overachieving perfectionist, you go, well, I'll show you. And then you don't even ask again because you don't want to be questioned for not being qualified. So you go over and above. In med school, it's like, well, how no one else can get to this? Like, look at you. How dare you take a spot from someone else? Like, you've always wanted to do it. You're just saying that because it's hard. Like, whatever sort of gaslighty thing kind of comes up. And so, like, all along the way, anytime you question it, it comes with like pretty significant fight from elsewhere that then kind of pulls on different parts of your psyche to ignore that.
Right.
And I think that happens in so many people where like you're like in the field for 10 years and then you get to breathe and then you go, oh wait, like what am I doing? And I think that's why it's really hard, because your whole identity got shaped into that and you don't know anything else. It's a really hard thing that way. I always tell students, like, the one thing I would say to them is like, actually give yourself time to question it and don't beat yourself up for it, like any step of the way. Med school, college, whatever, like take the time to be like, I'm questioning that for a reason. And like, I should ask myself that and sit with that. And if I don't know the answer, it's okay. But it doesn't mean I don't deserve to be here. It actually means you're thinking about this in a much smarter way.
Thank you. Thank you for that. Um, can you talk a little bit about this is going to be total shift, but I don't remember what chapter was in, but you were talking about, I think it was with the client Megan, and you were talking about cognitive distortions. And I see a lot of students that have like pretty significant cognitive distortions. And I wonder if like you could talk about what you mean by cognitive distortions and specifically like within like kind of the book and how that came up, because I actually I saw that throughout the book, even if it wasn't like labeled as like cognitive distortion, and the what 31 or 32 different cognitive distortions that we possibly have or whatever. Yeah, could you talk a little bit about that? And I'm happy to reference the page if you need it, because I'm like
A bit. Yeah. I mean, I think, like the simplest answer of how I think about this stuff is like, there are some thinking patterns that a lot of us have, and they're similar. And the way that we think and the things that we jump to are really similar. So we might overgeneralize something, we might intellectualize something. It might be how we're coping, but it also just might be our way of processing. And all of us do it very similarly. So enough that they can label them and say that there are these different types, right? So a distortion is just like the way you're viewing a certain thing in your head or in and processing something that is like you can kind of pull back and look deeper and find this like underneath it kind of. I think, or like more broadly label it that way. I think that we see it all over the place in so many ways, and that it's helpful to notice when you do it because, labeling things in this sense can be helpful because you can say, there goes my brain again doing that thing that it always does. And how do I get out of it? Oh, I have to do that thing that I always do. Right. And so it can help. I think it comes up in like, self compassion a lot because I think a lot of the cognitive distortions can lead you to really be mean to yourself and be mean to the little things that happen in your life. Like, I messed this one thing up. How dare I ever be a doctor? I don't know how I got here. Like, blah, blah. Like, there's just huge things. And you have to reframe that and think about how you talk to a friend and think about how you would talk to a little version of yourself, whatever it is, because you would never say that to yourself, like if you were actually saying it to a friend, right? Um, so it comes up in a lot of ways because our brains aren't very nice to us. And I think it's really helpful to identify the ways that that is and try to work on it because the patterns of our thinking and the patterns of our, like, negative ways of thinking about ourselves and others, and it can help us better adapt to the world that we live in and the interactions that we have with ourselves and others.
Where do you think those distortions like often come from? Like, I mean, is there kind of a magma chamber where like I mean, is that a trauma background, or is it really just a way for us to um engage in pattern recognition or prediction, but we just mess up because we're flawed?
Hmm. Both, maybe. Like, I bet some of them have like more drawing dotted lines to trauma, but I would assume most are just like things that we've over time taught ourselves to cope, self-soothe in a way, or self-hatred for motivation in a way. I think you'll see a lot of folks that are high achieving like aren't very nice to themselves, and that helps. They'll say, I don't want to change that. Like, that's why I do that. Like, the only reason I run is because I tell myself I'm fat, right? Like, whatever it is, like,
Right.
they're not nice to themselves, and that's their motivation. So they don't love you saying, like, no, that's like, that's not good. Like, let's try to think of a different way of thinking about that. And so it can be hard, but I do think it's probably comes from all of those things kind of interacting. And then like probably there's cultural things in there too.
Right. Right. What do you when you were writing this, like, what were you hoping people would get out of this? Because I think, and tell me if I get this wrong for you, but I think when people write, they have an audience or a specific person that they're writing to,
Hmm.
and they want to communicate something kind of like, whether it's a zeitgeist that they're observing, or a set of skills or whatever. What were you hoping people would take from this?
Yeah. I mean, that's a good question. I mean, I think for me, I was having a lot of conversations with patients where they'd be like, I'm the only one who feels like that, or I'm the only one who's ever experienced that. And I think first and foremost, I wanted to say, like, no, like, not only did I experience it as a clinician who might see you, but so do all my patients. And you're not special in that sense where you're somehow the only one. And I think that was a big reason for wanting to write it. I also think that like connecting the dots between the workplace and our well-being, especially when the workplace is a caregiving workplace, is important, was really important for me. So like understanding that, like, of course your work affects you, not the other, like it shouldn't be a surprise or a shock or a punishment. It should be an obvious thing that it does that we then talk about and then we then help with. And like a lot of the things you can do are not earth shattering. They're quite simple and they can help a lot. Um, and it's not your fault that working as a psychiatrist in the middle of a pandemic who sees healthcare workers, you might burn out, right? And I think I needed to hear that from me. Um, like to work through it and write it for me. But I also think that I feel like my patients did too. And my friends and.
It definitely, um, it felt like reading a series of journal entries. It seemed like very vulnerable, very authentic, very honest. Yeah, but
Thank you.
and
I
I
think there
also
are things like, like stories that I choose not to tell because of what I do and and I think when people think about vulnerability, they just need to realize that, like, it doesn't mean you have to tell everything, that you can still have boundaries. But I
right.
think I made choices for my own comfort level, and I know where this pushed me more than most things that I write. But I chose to put everything I put in there and made mindful decisions about where to put boundaries. And I think you're allowed to do that when it's your story.
Yeah, I think it's great. Um, any plans for upcoming anything upcoming? Another book or any other projects that you're working on outside of UT?
I'm like really excited about my day job and trying to do a good job in my day job. Still seeing patients on top of it is hard, and so trying to balance that is really important. But I felt like I couldn't be a person in leadership who didn't have a connection to what was going on the ground. So it's really important for me to still see patients. You won't see that in a lot of leaders, but you also won't see that in a lot of talking heads on television. So it was really important to me to be a person who's grounded in my own experience from what I was hearing from work and day to day, like, patient care. Um, so book wise, I'm definitely just like, talking about the same one for a while. I'm not it took me 3 years ish to write it, and I think it's a hard process in general, and marketing things is not in line with it sort of runs counter to my own sort of like value system. And so I think it just takes a lot out of me to do. And so I think it'll
Mm,
be a little while before I can do that again, but it doesn't mean that I won't. I think I just have to really believe in something like I did this one. Like, I think if I'm able to say, like, this is the purpose and uh, like, kind of what you asked me, like, this can help people, then it's an extension of work instead of something that's somehow weirdly self-promoting, which, it can feel like when you're trying to get people to buy something. Um, so I think I need a break, but I'm hopefully going to start freelancing a bit more again once I sort of like have a downtime to find like a love of writing a bit again. That's not like work. But I love speaking. I'm always open to gigs like that, going to talk to people about this stuff and how to think about things. And like, that's always really fun for me for a different level, like getting to hear what people are doing and give feedback, or getting to work with groups or anything like that.
that sounds great. Well, Jesse, if folks want to get a hold of you, what's the best way to find you on the socials or that sounded like an I
Yeah.
think old people say
Where
that.
do they find me on the social? I'm at Dr. Jessi Gold on most platforms. Jessi spelled Jessi, like Jessica without the CA. My website's drjessigold.com. That has like all my writing, all my podcasts and things that go there. But you can also contact me through that. So that's the easiest. It goes right to my email. And that's by far the easiest way to find me.
Great. I will put that in the show notes along with all of the other things that we referenced today. And Jesse, I appreciate you so much coming on
Of
and
course.
talking with me and putting up with my ridiculous questions.
No ridiculous
So,
questions.
um, thank you so much for joining us today.
Thanks for having me.
Before you head off, I just wanted to say thanks for tuning in today. All of the resources discussed are in the show notes below. And one last thing, if you know anyone that would benefit from this episode, please forward it along to them. If you liked what you heard, please subscribe to my podcast, the YouTube channel, and the newsletter. All right, see you all next time.